Today is a very important day for us at Bionourisso. In 38 days, we will have the pleasure to welcome Dr. Thierry Hertoghe in our Congress on November 17th to the 19th in Mexico City in Fiesta Americana, Reforma. Dr. Thierry Hertoghe has a lot of experience in bioidentical hormone treatment, and he will be sharing his knowledge throughout our third Congress. After this webinar, you will learn a lot and you will have a Q&A session opportunity. After that, I'm going to explain more in detail how to do your registration and how to know more about this Congress. So, give me the privilege to welcome Dr. Thierry Hertoghe. Doctor, thank you, and the floor is all yours. We're very eager to know and hear more about you.
Thomas Brown, I'm very honored to be able to talk to you. I won't talk in Spanish. My Spanish is not optimal yet. I probably can answer questions in Spanish. And I will give a talk on really very important items and hormone issues for men and women. So really things that are different for men than for women and vice versa. So let me share you my screen. Here it is, and share. And this is my PowerPoint presentation. And that's it. Yeah. So if you need to get the translation in Spanish, you go into where everything's said here, you really can get it. And it's a very good one. Out of experience, I know it. Thank you for the translator of being there. So it's actually a short overview that I give of the hormone therapy workshop of 2 days I'm giving in Mexico City in November 17, 18, like Thomas just talked about. And we'll first start with what hormone therapies can improve women. We know that women is so important. It's half of humanity and so even a little bit more. So it's very good that we take good care of our women. If you have happy women around, you're happy too. So what are the main hormones to improve women? Well, there's thyroid hormones, there's growth hormone, there is MSH. We'll see what melanocite stimulating hormone, how important it is for female sexuality. And there will be also estrogens, progesterone, and testosterone, the 6 hormones that also improve women the most. So these are, let's say, major hormones for women that I'll be talking about in Mexico. And I'll give you some of the clues that we'll be able to see at that moment. So put it here. So, for example, when you look at a woman who's deficient in those main hormones that estrogens, testosterone, growth hormone deficient are, she looks like this with a bloated belly and some atrophy in the body. But so this estrogen deficient face is typically a pale face, loss of this oval feminine face. It looks here more masculine with more angular face, and that's not typically feminine. That's not reflects a lack of estrogens. And then their flat scalp here is a lack of estrogens, but also lack of testosterone. It's not testosterone that makes women lose hair. It is the dihydrotestosterone. So if you have a lot of testosterone, women is good. And if you don't have enough testosterone, you have flat scalp here, muscle loss. And also growth hormone is just so older looking with abdominal obesity typically. That's how we go with age. And I can tell you, there's some very, very new information that are really major that can reverse 5 to 10 years, men and women. I'm actually on the treatment like this since 1 month. I can tell you it's very, very important. It's very old treatment, but it works as well as growth hormone IGF-1 to change the looks to improve people. And so, but here I'm going to the basic hormones, you know, about the 6 hormones with growth hormone can give this better build of body with actually belly, the abdomen that is also better formed. And so this is what we need to do in our therapy. As physicians, as medical doctors, as health professionals, we need to reverse aging because that makes our patient healthier and happier, feeling better. So here, for example, is a woman with low estrogens. Look, she looks pale, she's angular face, etc. And this is typically the oval feminine face of women. When they get estrogen therapy, they get this much rounder face. And that generally reflects sufficient estrogens. And so you see also the hair volume is more thanks to the estrogens, and there's more rose cheeks, more blood supply, and there's also the more volume to the face in a certain sense, and really more feminine face. And in studies, this is what men prefer. When they see pictures, they are more attracted to the more feminine face. That doesn't mean that there's a difference in worth of all, because I believe everybody is not equal, is not superior, is not inferior, just different. And that difference makes our attraction and the way we enrich other people. And so this is a woman of 42 years, and during 18 years, she was on undetected growth hormone deficiency. And when she received during 2 years growth hormone, this is the change. See what a change. 2 years of growth. That shows you how hormones can rejuvenate the body and make the body firm. If you want to rejuvenate, you need to make the body firmer. And you see, this is droopy breast, estrogen deficient breast. They are less voluminous. There's droopy. And with estrogen and progesterone treatment, you always need to give progesterone when you give estrogens. You get this more round shape, more voluminous and fuller breast. And you are actually firmer, and they're situated higher on the chest. So really, this is important. Don't let a woman with droopy breast because she's suffering from estrogen deficiency. So constant fatigue can be depression and low energy. So there's many reasons to treat not the physical signs of hormone deficiency, the hormone deficiency. And that's something learned in my workshops, and also I will do in the workshop I'll do the upcoming month. And you see, in 2 to 4 months, it's enough to get these breasts better. But you need to add growth hormone in women older than 35, 40 years, or you cannot really have this good effect. So it's a multiple hormone replacement that we need to check after age 35, 40. And cellulite is mainly a testosterone deficiency. And when you look, you give testosterone, this is what you can get. But you need often to go on supraphysiological dose. Once you have cellulite, the hormones don't go there. You need to give a little bit higher amount. And in order to protect the woman from masculinization, you provide finasteride during the time. And the doses can sometimes be high, but are safe on condition you give enough testosterone. Testosterone makes finasteride safe. And so you also daily thigh exercises. Testosterone doesn't work in a muscle that is not used, so you need to train that. Do 2 times 10 minutes thigh exercises, and you can get very great effects. I even add sometimes testosterone cream 1% and anti-androgens. So you get that sort of aspect thanks to this combined approach where testosterone has a central role. And then what about these swollen calves? Well, in hypothyroidism, you have thicker calves. With non-pitting edema, you cannot put a little pit in. And with thyroidine, you get this sort of aspect with euthyroidism. So you get slimmer calves. And so it's not something that is genetically determined where you cannot do anything. No, it is really improvable and very reducible. And what about women who have problems of enjoying sex? They don't like sex. It hurts them, etc. And don't have pleasure, don't have orgasm. Well, there's a lot of strong tools where I will talk in my upcoming seminar, but you will see that the testosterone increases libido. That's the #1 libido hormone. Estrogens increase the libido, but testosterone 3 times more. And oxytocin, wonderful hormone. I take it myself. I can tell you I'm happy about it. And it gives you more romanticism. you also feel more warm-hearted as a woman, but also as a man. If when you take it and you have more pleasure, and the orgasm is more frequent and more intense. It's really, really, really a pleasure hormone that works. And you have also MSH, melatonin-2, PT141. It's also another form of MSH derivative, melanocyte-stimulating hormone. They don't only darken the skin, but they really provide more potency for physical sex. You enjoy sex more, and the skin is all over sensitive to touch and to excitement. So it really makes your body excited as a woman, very strong. And there's PT141 is VS sold as officially to women in the United States, but at a high dose. So I don't think you need that high doses. Smaller doses are as good or even better. Now, you probably wondered, what does love look about? Molecular. Well, very easy. Just look at the molecule of oxytocin. That's how love looks like. If you want to have a view on love that is, I would say, scientific, here it is. It's all love. It brings love. It really makes you fall in love with people. You like people more. And I can tell you that oxytocin has changed my life. I don't like people more alone. I like them more, but I love them more, and I like the world around me more. It gives you much more love feelings. And so it also improves the gaze, eye gaze. When you look, you take, for example, intranasal oxytocin, and it increases the number of eye fixations, really makes you romantic. Total gaze time toward the eye region. And you would think it's only in women? No. This study was done actually in men, and men had more eye gaze. They looked more in the eyes and with love in the eyes. Well, so, and what about an MSH derivative like bremelanotide? Well, when you look at the feelings of arousal, placebo, 20% of women get gently aroused, but with bremelanotide, it is actually more than 70%. And what about sexual desire? Placebo, also something like 15% of women get sexual desire, but with bremelanotide, more than 50% get sexual desire. So really it improves, and some women even, it makes them feel incredibly sexy or sexual all over the body, and it's a good thing. We have a hard life. You see all these wars we're having, and all these bad news, and the tax control, and all those frustrations. We need to have pleasure in our life, and so sexual pleasure is, for me, one of the most important ways to see that you get into the present time, you enjoy the present time, and you like living. So why not improve in your patients sexual arousal and desire and love and good feelings. Now let's look at what these hormone therapies can do to improve disease in women. And let's take an example. You see here an enlarged heart, and that is in heart failure. If you can provide estrogen therapy, can make the heart healthier. You can provide growth hormone and IGF-1, can also make the heart healthier. I have a whole model on this that is probably my best model ever, on everything you can do with hormones to improve arrhythmia, to improve heart failure, to prevent coronary heart disease. And so let's look at what happens with progesterone. You see, these are women where the ovaries, these are female monkeys where the ovaries have been taken away. And they inject in these female monkeys serotonin. And what serotonin does, it causes, in high doses, so don't be afraid if you take an serotonin uptake inhibitor, where you have more serotonin, it's higher amounts of serotonin here, and that gives a severe vasoconstriction, coronary vasospasm. You see it here. This is the coronary vasospasm. So that the coronary artery is decreased by more than 75%, more than 3/4. And that can create a heart attack. And when you give estradiol, it doesn't help. There's no significant effect. The coronary vasospasm remains. But if you provide progesterone, and it's only 100 nanograms, 0.1 milligram, small dose, but injected where it should in the coronary artery, you can, in 3 minutes relieve. You increase the vasodilatation of coronary arteries almost completely from 0.3 to 1.3 millimeters. And it's complete restoration in 8 minutes. So if ever something happens like a coronary vasospasma, the main cause of myocardial infarction, of heart attacks in women, progesterone. Take immediately progesterone, put it sublingual, open up the capsules, and try also to swallow it, and maybe take 4 capsules. There will be then enough going to the coronary artery, but you need also part to try to absorb it sublingual by opening up the capsule. Doesn't have a good taste, but it's okay if it saves your life and saves your heart. And so rapid vasodilatory action of progesterone. Now let's look what estrogens can do. Well, estrogens, and this is a big study in 48,470 postmenopausal women, those who received estrogen therapy during 10 years, after 10 years, there was a minus 44% decrease in myocardial infarction mortality. Much less died of heart attacks. And it's another study that where women were examined, more than 8,000, and after 1 year of estrogen therapy, 28% reduction in acute myocardial infarction mortality. And it was 22% after more than 15 years of use. So their studies go in the same direction. They don't always see the same data, but it goes to show that estrogen therapy is safe for the heart of women and even protects the heart from myocardial infarction. And this is a study on adults with growth hormone deficiency, and those untreated growth hormone deficient patients have 40% more myocardial infarction. And the men 20%, but the women 90% more. It doubles their risk of myocardial infarction. So it shows that also growth hormone is important to prevent myocardial infarction. If you don't have enough, you get easier those myocardial infarctions. And I did a study on the patients who came to the clinic where we treat patients. We treat a lot of patients, and we try to take really our time with patients so you can have good results. Well, I checked about more than 300 patients, and they were followed up for more than 6.5 years. I mean, follow-up of 6.5 years, some 18 years, some 18 years. The minimum follow-up was at least 2 years. And you see that the incidence of new coronary artery disease, of new heart disease, was much decreased in those women who were taking those multiple hormone therapies and multiple nutritional therapies that we gave, compared to what USA women have, and also the men about the same sort of more than 30% decrease in new coronary artery disease. And you must know that many patients come to our clinic come also because they have a disease. So even that, we don't get worse results, we get better results than the average population. And what about inflammation? Can hormones do something against inflammation? Well, there's a lot of information in the November workshop that I will give. I will talk about lupus and about how hormones can help to decrease lupus. And one of these therapies is testosterone therapy. Here it's testosterone therapy given in a weak dose of testosterone, transdermal patches. And there was a difference. It did improve actually the patient, but not clinically meaningful because the dose is too low actually. So there's a small improvement in health transition, but it was safe, but did not affect disease activity because you need to give the right dose. I'll tell much about the right dose. It's very important that you as a health professional don't know that something is possible, but you know how to do it and make it possible. Make it true for your patients. And here's, we'll talk also about fertility, how can you improve the fertility in women. And one of these ways is providing melatonin. Very strange because melatonin is known to calm down the ovaries, but that's not true in the pregnancy. In pregnancy, stimulates hormone production. And what about fertility? Well, 10 women received 3 milligrams a day of melatonin, and they had a second in vitro fertilization cycle. It improved less free radicals in all the process. It improved the egg cell quality, and there was more than an increase of 50% higher number of egg cells that could be taken away of these women because they ovulated better with the melatonin, and it was 20% more mature oocytes, egg cells, and 40% more fertilized egg cells. So there were more than double more transferable embryos, and it actually there were 50% more clinical pregnancies because these women received at bedtime 3 milligrams a day. Interesting, some women would also receive 6 milligrams, and they had also good results, but not as good as the 3 milligrams. Well, 3 milligrams is the good dose orally. It's a high dose. It's not a dose I propose outside of a disease or you need to stimulate the fertility, but you see, it does have a good effect. And there were 50% higher full-term pregnancy, so 50% more babies, thanks to this melatonin. Also, female hormones can improve disease in women, and estriol, an estrogen that is good for the mucosa, can decrease urinary infections. And how strong is it? Well, 3 milligrams a day of estriol given orally, to give it by mouth, it helps also the vagina and the bladder, and there was 15 times less urinary infections. Imagine. So it almost made all these women free of urinary infections. So also important to know is that many women have urinary incontinence. The way I do it to know it is I have it in the questionnaire. If they respond in the questionnaire, I have urinary incontinence, at least I can talk about that and give a solution. And of course, you need to have foods that make a woman bloat. You avoid them. She should avoid them. But you need to give a topical hormone therapy, and that is a very efficient treatment. Local vaginal estriol can be given. It does help also, but not as much as the testosterone. So basically what I do is I give a small amount of testosterone cream. They may not put a thick layer, a thin layer around the opening of the urethra, of the urine tube. And they should do then 10 or 20 contractions with the bladder. And each time they do it once or twice a day. The testosterone cream can be a 0.5% cream, and you take very small fraction, just a fraction necessary. It's better to do it more frequent with a small layer than a thick layer. A thick layer can give a lot of problems. So there will be 10 to 20 contraction exercises for 6 to 12 weeks. And it's extremely efficient. I would say 85 to 95% decrease in urinary continence. So usually the women say, I don't have any urinary continence anymore, but it can take 6 to 12 weeks to get full results. And then what about polycystic ovarian syndrome, PCOS? Well, the real treatment is actually easy, but it's a multiple hormone replacement therapy, not just one treatment. So what happens is that many of these women have a lack of progesterone, so you supply progesterone. But basically what they have is that the LH is higher than FSH in the blood test, and estrone higher than estradiol. The reverse situation, the opposite situation of what happens normally in healthy women. And they have a lot of more male hormones, so they get acne, they get hair of growth, and you see the cyst in the ovaries. So you need to improve ovulation for that. And one of the things is to improve the balance. There must be more estrogens than progesterone, but you still need to increase the progesterone. And so I correct both deficiencies. I give transdermal estradiol and I give progesterone, and I follow the menstrual cycle. You can find that in my hormone handbook, all the specifics. But you can I will also talk it abundantly in the workshop I will give. And you also correct estradiol thyroid deficiency, because thyroid hormones stimulate ovulation. In the years 1950 and beginning 1960s, thyroid hormones were considered as the #1 treatment to improve fertility in women. And thus, by increasing the ovulation, they stimulate the ovaries to work better. And I would propose here desiccated thyroid works better than the other preparations. And also you need to correct cortisol deficient. A woman does not ovulate well if she doesn't make enough cortisol. And many of these women have what is called adrenal genital syndrome. That means that they make more male adrenal androgens than they make cortisol. Cortisol is failing, so they compensate with androgens. And you reverse the situation by providing cortisol to these patients without DHEA and other androgens, because they have enough of those. You need to decrease them. You follow up with 24-hour urine. And you can eventually correct iodine deficiency, because when there are cysts, iodine decreases cyst formation. If, for example, 5 drops per day of 5% Ligol or 2 iodoral tablets, we have in our pharmacies capsules we make that are made with potassium iodide, and that works really good. And what about endometriosis? Also one of those treatments that they say surgery is the only solution. Surgery should be the last solution. It's not the only, it's the least solution. You don't solve anything with surgery, except that temporarily you help the patient not suffering from endometriosis. But why not treat the cause? And what is the cause in endometriosis? Well, you see that these women have pain. They're excited. They suffer. And it's very, very painful with ups and downs. And what they have is endometrial plaques. They have plaques of tissue that normally should be in uterus that has arrived in the intestinal cavity, in the abdominal cavity. And it flares up with moments, and that does more pain, and then less flare-ups. So there are small little lesions that you have here. Okay, here, for example, and there. And what happens is that a main deficiency behind endometriosis is progesterone deficiency. When you have progesterone deficiency, what happens to the uterus? Well, what you have contractions in all ways, and it's not homogeneous, those contractions. So that will help by these irregular contractions to sooner or later have some of the mucosa here arrive there where the ovaries are, but arrive then in the abdominal cabin. And so you get this sort of woof. And then you have endometrial plaques in the endometrial cavity around the uterus, but also further on in the abdominal cavity. And that hurts. When there's follicular phase, proliferation of those, it will hurt more and they will grow. So you need to add progesterone. And what I do is I always give a synthetic derivative that is safe. There's one that is a feminine progesterone, and that's dydrogesterone. I think you have it in Mexico, might not have it in the United States. And so I give this, and I can, in severe endometriosis, I can give it from the 5th day of the cycle, a small dose, and then a higher amount in the 2nd phase of the cycle, from the 15th to 25th or 26th day of the cycle, with good results. Same sort of treatment you can give with fibroids. And but sooner or later, you might have to correct also thyroid deficiency, because thyroid hormones will make this person ovulate more, make more progesterone. Same for cortisol. If there's cortisol deficiency, provide hydrocortisone, and they will ovulate better. If they really have a lot of inflammation, you might have to give prednisolone or methylprednisolone that has a more persistent effect, 24-hour effect in the body, than hydrocortisone that you need normally to multiply the intakes. And then improve the food. Dairy products will upset the intestines, inflame it. Sweets also, unsprouted grains, unsprouted nuts too. And then you get also more pain because of the inflammation in the abdominal cavity. So it should be a safe food that reduces inflammation. And that's fresh vegetables and fruits, boiled possibly, and meat and fish cooked inadequate way, so never with any plant oil, even coconut oil, still a little bit toxic when you put it at a high temperature. And then let's look at some of the problems that withhold people of doing therapy is they're afraid of cancer. If you're afraid of cancer, go to a right hormone therapies that can set your hormones straight and you'll have less risk. So breast cancer recurrence, the recommendation, if you had breast cancer, there's no study that really has shown that if you give a treatment after breast cancer, you would have increased breast cancer recurrence and mortality. So that HRT, female hormone replacement therapy, is an option in women after the menopause who had previously breast cancer, following this Society of Canadian Obstetricians and Gynecologists. And what you see is that when you provide, for example, female hormone replacement therapy to women who had breast cancer, it decreased the recurrence by 50% in this study. The mortality by breast cancer 66% and total mortality by 52%. So it's worth doing. And we do it in our patients. Of course, we do let a certain time of 2 to 5 years where we provide often no treatment with female hormones, but with thyroid, melatonin, and other hormones we do. Unless they get a lot of problems, then we intervene sooner. But generally, because there's so many scare of cancer that we often give this 5 years pause, as that we know that everything's getting safe, that the patient has had her breast cancer removed by surgically, and that it's okay. Now, interesting is to see is that the women who took testosterone in the treatment generally have had less cancer than women who just took female hormones. And women who only took testosterone, testosterone implants, had also less cancer than never users of hormones. So it's quite interesting to see how efficient also testosterone can be. It's you wouldn't even believe your eyes, but there's a study showing that if you put around the tumor testosterone implants, it shrinks the tumor more than 10 times. It takes several weeks, but it's quite efficient. But that's anecdotal evidence. Now let's look at hormone therapies that improve men. Without men, what would women do? Without women, what would men do? So basically, it's very important that the men also are well treated. That makes the family happy, that makes the people at the profession happy, and he becomes also efficient, and he can fulfill his destiny much better. So what are the important hormones? Growth hormones, certainly made by the pituitary gland. Menosis-stimulating hormone, also made by the pituitary gland, anterior pituitary gland, actually. And then you have thyroid hormones also, that you see here, and testosterone, they're made by the testicles. So these are the main hormones that can influence and make a man feel strong, look good, and be potent sexually. And so testosterone and growth hormone deficient man looks like this. And what you see here, he has a loss of the inner third of the eyebrow. That is due to testosterone deficit. There are 2 studies who show that. And there's a growth hormone deficiency is loss of the middle third of the eyebrow, this middle third. And testosterone deficiency is a loss of masculinity and health. And so you get a less firm face. And growth hormone deficiency is sort of atrophy and loss of youthfulness with sagging cheeks. And testosterone growth hormone deficient, that's how we look. I don't mean that when we give all these hormones, we can get this result, but we're getting very close to that result. And let's look at hypothyroidism. This is a picture of a patient of my great-grandfather, because it's already 4 generations that we treat thyroid deficiencies in our patients. And my great-grandfather was one of the pioneers of that time. He wrote books on thyroid deficiency and how to treat it mostly. Just get a thyroid treatment and see the result, how finer the face looks, how we can change faces of our patients just with thyroid hormones. And then this is a patient, one of my first patients to whom I gave growth hormone, and see the difference. Hair thinning, eyebrow thinning, droopy eyelids, looks older, and it's just 15 years. Deep wrinkles, sagging cheeks. And with growth hormone treatment, see how the face is firmer, better, looks better. And the hair is voluminous. There's less droopy eyelids, and you don't see the sagging cheeks anymore that you saw here. And the greatest result, he felt so much better. Here he was exhausted, there he felt better. So we really have powerful hormones that can improve our male and female patients. Masculinization, there's typically a young man low in testosterone. When he takes testosterone, look at the change. Looks good. Testosterone treatment, adequate. And you can do this. And how long does it take to change the aspect? Well, you need 2 to 8 months. So I would say 8 months. 2 is the beginning of the improvement. 8 months is to get full improvement like this. With exercise, you cannot get more muscles with testosterone if you don't exercise. Fatty abdomen, testosterone deficiency, fat, non-droopy abdomen is typically for low testosterone. And look at with testosterone can give the result, the change, same person, change. With abdominal exercises also need 2 to 8 months to get that result. And what about growth hormone deficiency? This is a study in patients who got growth hormone deficiency in adulthood. They have a fatty, droopy abdomen. That is characteristic to growth hormone deficiency. It's not characteristic to aging, to growth hormone deficiency it is characteristic. And it takes about 6 months to get that sort of result. And also with a weight loss diet if possible. And you get, in this study, in these patients, in the 6 months, they had 2.5 kilos more muscle mass. And they had more extracellular fluid volume, or water in the body. But 6 kilos less body fat. Mostly visceral fat. That's the visceral fat. The subcutaneous fat is under the skin. But you see the results. And of course, they had higher IGF-1 levels, that is, and then even T3 was higher, and they felt so much better in the mind. They had less psychiatric scores. And what about the sex in men? It's so important for men because they feel less than a man if they don't have good erection. It's so, can change the things if you're very religious or very prude or whatever, are very characteristic that you should never talk about sex. You're in the wrong program, because sex is part of our life, gives again our pleasure that we need to compensate for the hardship. Why not compensate? Very often if you can, and that you can do with good hormone therapy. So if there's a problem, you give testosterone, you will increase penile sensitivity and the frequency of morning erections and spontaneous erection gets better. Also, ejaculation can be better, especially with dihydrotestosterone. But to get really hard erections and of long duration with big volume, you need to give growth hormone IGF-1 and dihydrotestosterone possibly, but also MSH can help, like melatonin-2 derivative of MSH or PD-141, that is the same as premaltine. They can give you really strong and hard erections. And what about, so you see that men with erectile dysfunction in Southern Korea, they had significantly low serum testosterone. However, a meta-analysis of 14 studies with more than 2,000 men showed that when you give testosterone treatment to men who had age-related testosterone deficiency, you improve the libido, you also improve the erectile dysfunction, but it's a marginal improvement, a 2.3 points increase in the International Index of Erectile Function, and where you can go to 30. So 2.3 is not much, because erectile dysfunction is due to multiple hormone deficiencies. You need to give all the hormones together to get really adequate results. And so there was better results in those men who had the lowest testosterone levels, which seems reasonable because you give the biggest difference to these men. It was significant better also in men with, or not so good with men with pathological medical conditions. It also improved orgasm, intercourse satisfaction, and overall sexual satisfaction. But I can tell you, testosterone can be very potent if you're already under multiple hormone replacement therapy with growth hormone, for example. You get really good results. And so you see here, for example, during the increase of penis, what happens is that in the blood and in the penis, in the corpora cavernosa, growth hormone increases and almost doubles in volume. So you get this sort of erection. I hope that is not your penis. It's a little jokey I'm showing here, but the facts are not joked. There's more growth hormone in the penis and in the blood of patients who start having an erection. So it must have a role somewhere. And it's seen that growth hormone really does give more duration and more volume and more hardness to the erections. And so these are men with all types of erectile dysfunction, physical or psychological erectile dysfunction. If they receive Melanotan 2, that's the most potent of the MSH derivatives to improve sexuality. If they get it injected subcutaneously under the skin, that improves their sexual desire. And 63% of these patients who couldn't get erections got erections. And the erections duration of the rigidity of the tip of the glans penis, more than 80%, is 45 minutes compared to the 2 minutes of before. So it makes a major difference. And so it really improves it if they have received a relatively high amount here, and it gives some transient nausea and yawning. So I once took a dose that was too high. I just made an error, took 10 times more. I can tell you I had terrible nausea. And to increase morning and spontaneous erections, maybe DHA could help, but it works slowly, it takes time. And what you see here is actually the men with placebo. They, during the 24 weeks of the trial, the erectile dysfunction score, function score decreased. They had less good erections. However, with DHEA, it slowly increased. 8 weeks, not much improvement, but after 16 weeks, almost 4 months, good improvement and almost perfect improvement after 24 weeks, which is something like 5 months and a half. So basically very, very good result. But you need time. It's very slow to go. It's with 50 milligrams per day of DHA in men. Also, these hormone therapies in men can also improve disease. Also, in focusing on the heart, testosterone is probably extremely important for the heart. Use it, you see, you can get a healthier heart that is more compact and not this enlarged heart that is weak. And growth hormone and IGF-1 are major treatments to improve the heart. Also, thyroid hormones. These are my 3 groups of hormone that I prefer to give when there is heart failure. But it works also for coronary heart disease and other things. So let's look, for example, you see that a low IGF-1 means low growth hormone activity. If you're in the lower reference range here, you have an increased risk of ischemic heart disease. If you have increased angina pectoris or myocardial infarction, also here, if you're in the lower half or 2/3 of the reference range, and then if you have a decreased risk of ischemic heart disease mortality here, if you're in the lower 80%. So there is, you need to be high normal to be in a healthy zone. So oral testosterone indicanoate, if you take that for a month, there's 77% of men have decreased angina pectoris symptoms. 75% of men less have myocardial ischemia signs and less on the ECG. So basically it works well. And let's look at myocardial infarction, and these are almost 40,000 middle-aged men, aged 46 years, and half of them received testosterone intramuscular injections for 5 years. What is the difference with men who didn't receive testosterone and were of the same age? 7 times less heart attacks. That's enormous. But it's so. And you have something similar with growth hormone treatment. So if you combine growth hormone and testosterone, what will you have? So growth hormone treatment, these are growth hormone deficient patients, and about almost 300. And those 289 growth hormone deficient patients received during 5 years growth hormone. And compared to the normal Swedish population, thanks to the growth hormone treatment, they have 3 to 4 times less myocardial infarction compared to the Swedish normal population. Men 67% and women 100%. Women, no woman had any myocardial infarction of the group. And there were a lot of women. Also, you see that testosterone supplement can also decrease lupus in a man. This is anecdotal. This is typical like Klinefelter syndrome, a man with some more breast and minimum facial hair and body hair. And they can have systemic lupus erythematosus. So they have the lupus, the wolf disease. And so the face looks like a wolf normally. They were treated with testosterone in doses sufficient to normalize the serum level of this hormone to the adult male range, because they normally have extremely low testosterone levels. And there was really improvement in the blood with a decrease of anti-DNA antibodies. So it was helpful also to men, not only to women, the testosterone in lupus. And what about prostate cancer recurrence in men who had previous prostate cancer and received testosterone? Well, first of all, the risk of prostate cancer per unit decrease of serum testosterone is 26% increased prostate cancer risk. So the lower you are in the serum testosterone, the more there's a prostate cancer risk. And men with confirmed prostate cancer, it showed, compared to healthy controls, when you take all these groups, you saw that the lower the dihydrotestosterone is, the super male hormone that gives you body hair growth and bird growth, makes you lose your hair here, actually also increases the prostate cancer risk. So this is the opposite of what we've been taught. Testosterone decreases the prostate cancer risk, and low testosterone increases the prostate cancer risk. And for dihydrotestosterone, it's the same. So in this retrospective study of prostate cancer patients, so 100 men who had prostate cancer, but it was removed. And they received testosterone, transdermal testosterone, during more than 2 years. And basically, there was a little increase of serum PSA, but little, it was so small normally without treatment that it's of non-significant. But what's interesting is to see is that those who were treated with testosterone had 4 times less overall prostate recurrence. Only 3.9% had prostate cancer recurrence, while in the cases who were not treated with testosterone, 16.3%. Now, I'm going to end also by telling some frequency of testosterone. You see here, testosterone deficiency is frequent in men, very frequent. It's not just 1 man on 100. It's much more. So let's look into the facts. The testosterone deficiency in men also starts early, around age 25 and 30 years, not at age 60. And you see all these men, oh, they look quite masculine. But do they really look fully masculine? All these men are testosterone deficiency. They are pale faces, their cheek is less firm, and their hair is getting flat. So the young man maybe is too young to get testosterone deficiency. But look at this man too, because his hair is flat, he's pale, his eyes are dry. and it doesn't look so firm in the face. So maybe they work too much, these people. It's possible. But whatever it is, here we are seeing on physical examination, when we just look at them, we already are starting our physical examination, we see testosterone deficient. So testosterone is frequent. And this are the testicles. That's how testicles look like. Might not look the most beautiful thing, but there is the beginning of humanity, in the sense from there are cells, spermatozoids, that will fertilize egg cells. And here is all those spermatozoids that will fertilize egg cells. But here in between those tubes here are actually Leydig cells that make testosterone. And in these several million dynamic Leydig cells. At age 80, only about a quarter of that, a little bit more than a quarter, 220 million lazy Leydig cells on autopsy studies, and they are not so functional. So how can you believe that an 80-year-old could have enough testosterone? That's scientifically not possible. And so there's, per decade, we are losing, each man is losing 80 million Leydig cells per decade. Now you're listening to this lecture. It takes about an hour. But you know that every 4 seconds, a man here who's in the audience is losing irreversibly 1 Leydig cell. And so there are 15 Leydig cells that make testosterone that are lost per minute, 900 per hour. So it's time actually to treat your patients on time. Don't wait. And testosterone, I made a book on this, and I think it's probably the most documented book, but also very interesting because of all the topics. It also tells you how to make a self-prostate examination, how to treat prostate hypertrophy, how to treat prostate cancer patients, how to decrease estrogen levels, what testosterone does, and how to recognize the symptoms. All that information is there, also with pictures and with graphics. Within the reference range, you have these in these disease zones where you should not be. You should have higher levels. So it all gives you all that information. And there was a growth hormone book I will be editing this autumn, but late autumn, so probably end of November. So here for this, I really think it's an interesting book. It's not too long, so it's really worth it and very exciting. It's on this format. And we have also a special offer that if you go on the Hertoghe Medical School.eu webinar, and you did this code webinar VIP, you're a VIP, huh? You know that you're a VIP. So webinar VIP, 15% off. And of online courses in English, we have courses in Spanish, professional books, postgraduate program, fellowships and certifications. Really interesting. You want to have certify your knowledge, you can do it here. Passive assistant training, you can come here and see, but if ever you come in the consultation, do a consultation also, so you get really the best learning. And hormone hotline, if you want to get help through phone or emails, really worth to do it. And we give medical education. You can push on this with your iPhone or mobile phone. And we have a cycle of this. Is the best, most modern and most updated program. Reversing physical aging, female hormone supplementation, chronic fatigue and burnout, thyroid diagnosis and treatment, melatonin, testosterone. And that cycle 2 is hormone therapy consultation. If you want to start, do this. Just, you can pick up them separately. They're very good. You have the adrenal hormone therapies, the growth hormone and IGF-1 therapies, really interesting. Longevity, I think, is one of the best courses you can find, if not the best, at least in hormones and lifestyle. And then the cardio and cerebrovascular diseases, not only for cardiologists, but very, very detailed for cardiologists too. And sexuality, really, you need that. And also the oxytocin treatment. So obesity is a course I still have to do. It will be end of June next year that this will be available. And so there are books. The Hormone Handbook is the #1 book to buy if ever you want to get it. And also the atlas. So the hormone really gives information. Everything that's in dark yellow and bright yellow is more important. So if you don't have time, go and look at what's with the yellow background. get a lot of different information, everything you ever dreamed of having with references. So you protects your practice. And then the atlas, you have more than 670 pictures of hormone deficiencies and excess. So it really learns you how to recognize just by looking at a person, the intensity of the hormone deficiency. Very important because this improves with treatment. Really, really interesting. And then you have this reversing physical aging book, really, really good. These books will be sold also in November, Mexico workshop. And my next events, there are several events. There's one I have normally next week. And you have the Bionourisso Congress in Mexico City. This is really important. I'm also talking in China, but virtual, not going there. And but very interesting topic to see before and after treatment, what happens with the physical exam, the body. And then this is the Bionourisso Congress in Mexico City, really, really where you have a lot of information. 2 days I give workshop, but I can tell you it will passion you. It's in English, of course, translated into Spanish. And then there's a conference end of November. I will be also in the A4M meeting. I will be in Genk somewhere in Belgium, talking also on hormones. And so I'm giving a very good talk on growth hormone deficiency in Las Vegas. So really interesting, with also key hormone lab tests. So really interesting to meet me in the A4M, because I also answer a lot of questions, and in the exhibits I do show people their deficiencies, so practical cases in direct. So you learn a lot with this. So I hope to see you. And these are links for our social networks. Really interesting. You can go Facebook, LinkedIn, and so on. So if you want, you can just take a picture of this, and then you know how to get on the social networks. There's always something new and interesting for you. And if you want to contact us, Hertoghe channel at hertoghe.eu. I think this is wrong. It should be the gmail.com here. So Hertoghe channel, gmail.com is better. And then the hertoghemedicalschool.eu is for the website. And then, Thomas, I think you should put your video on, and you're going to give some information. We'll have questions and answer after. So I thank you for your attention, but I expect your questions after, and there's already a list of questions. Thomas, can you just give a little word, and stop sharing my screen. I'll let you talk.
Absolutely. Thank you so much, Dr. Hertoghe. And if the host can please cut and paste the message I just wrote, I'm going to share some promotional information about the Congress. One of the messages I wrote is how to do the registration in both English and Spanish. And the other message I wrote in the chat is how to participate for the first 50 people that dial and text the 624 number. Gracias a ustedes para acompañarnos durante este gran webinar con el maestro, mi estimado mío, Dr. Terry Hertoghe. Les digo, pues, de una vez hacer sus registros. Ustedes pueden hacer su registro en la página de Canva. Tenemos páginas en ambos idiomas. Ustedes pueden ver esta información en el chat de este webinar. Y también vamos a tener una beca de los primeros 50 personas a hacer un mensaje por WhatsApp al número listado de 624 18 48 202. Otra vez es 624 18 48 202. Vamos a tener una oportunidad de aprendizaje de muchos temas interesantes, de 10 tratamientos de hormonas bioidénticas, enfermedades crónicas, inflamación, síntomas y desórdenes hormonales, y también disfunciones sexuales. También vamos a tener una cena gala para celebrar 10 años de Bionourisso. Ya tenemos 10 años sirviéndoles a ustedes en México, y ojalá que podamos compartir más conocimiento, más educación y más productos de la alta calidad en México. Otra vez, muchas gracias, doctor, y a ustedes para acompañar este webinar. Y ojalá que nos vemos en México el 17, 18 y 19 de noviembre en la fiesta americana en la Ciudad de México. También vamos a tener mi estimado el doctor Antonio Posada. Él es un experto en terapia hormonal en la forma de comprimidos subdérmicas. Él va a tratar de temas que se trata con cáncer de mama y testosterona. También vamos a tener una experta, la doctora Cara Fitzgerald del Instituto de Medicina Funcional. Ella va a hablar de medicina funcional y muchos temas de salud y nutrición, en cómo podemos relacionar nutrición y medicina con tratamientos hormonales. Entonces, les digo una última vez, hacer sus registros y disfrutar este webinar gratuito con el Dr. Terry Hertoghe. Doctor, por favor, hacer su sesión de preguntas o respuestas y nos vemos en México en 38 días. Gracias.
Okay,
Thank you, Doctor. Please go ahead with the Q&A session.
Thank you, Thomas. I'll come back. So we can have questions, and I have already questions here, so I will answer the first questions. And then here in Mexico, it's not possible to get desiccated thyroid of pork and levothyroxine and novotiral, levothyroxine and liothyronine are very unstable. What I need to do to treat hypothyroidism. Thomas, is that true that you cannot get desiccated thyroid? Thomas, do you hear me? Apparently, you haven't put your you should unmute, Thomas, because I think you can have it. Well, first of all, I think that the pharmacy that actually organizes everything in Mexico can have desiccated thyroid. If not, then you need to and eventually to give levothyroxine and T3, liothyronine or triiodothyronine separately, and maybe make a capsule of both or separate boats that you take together. But I do think you can get desiccated thyroid. I thought you can get thyroid, armothyroid in Mexico, but I see that Thomas has unblocked his phone. Thomas, do you hear me? Do you have desiccated thyroid in your pharmacy? No, doesn't hear. Okay, so we'll close that then. Okay, I will. The other question is, it's a good option to take bioidentical thyroid, or do you suggest to try to get natural desiccated thyroid of pork? I have been on 220 milligrams of armothyroid with great result. Stay on the treatment that works, and armothyroid is a very good treatment. We use thyroid from Canada, armothyroid is from the United States. Thyroid is a little bit better, I think. And but if you take, I would say, an organic brand without any preservative in it, it doesn't hold on. And for example, I took West thyroid or nature thyroid. If you let it in the shelf for more than a year, it doesn't work as well. While the others you can let maybe 8 years without problems, you can still use it. It hasn't lost its efficacy. Okay, in Mexico, it's possible to get hormones as thyroid or hydrocortisone with long delivery chemicals as carrier. What is better with or without long delivery chemicals as a carrier? I have not seen this in Belgium, Germany, or so in the United States and in some other countries, you can get long-acting hormone types. And you can get it for thyroid, and you can get it for T3, for example, long-acting T3, and you can get it for cortisol. I have tried them. Result, it doesn't work. It does work, but you need to give a dose that is 3 to 6 times higher to get efficacy, because the fact that it is bound to another molecule for increasing duration makes it less absorbable and more time to absorb it, because you need to break that bind or it's very difficult. So I don't find that those long-acting forms are good. It's enough to get thyroid hormones once a day and cortisol twice a day, or I even take cortisol once a day, because otherwise I forget, and it works well. So you don't need to bind it with a long-acting form that makes it lose its efficacy. And then it's okay. Will it be possible to get video access to this November workshop, please? I don't know. I don't think so. Thomas, if you are there, you can unblock your, you can unmute, and no, he doesn't unmute, so he's probably not there anymore. Okay, Timas.
Hey, doctor, I'm here. Sorry about that.
Okay, so
How
Thomas,
can I help you?
2 questions. One question is, do you have desiccated thyroid, like almond thyroid, in your pharmacy?
Yes, we do have thyroid medicines available in our pharmacy, T3, T4, and porcine thyroid. And what we can do is share information via WhatsApp or product list. So that same number I shared before, I'll be happy to send a product list to the folks who are interested. Si ustedes están interesados en los productos de tiroides, favor mandarnos un mensaje al número que ya les compartí. De nuevo, yo puedo decirles si están interesados.
The other question was, Thomas, will it be possible to get video access to the November workshop? The one we do now, for example, in October, and the one we do, will it be filmed or not?
No tenemos planes en grabar. Es un evento presencial. This event will be a in-person event.
Okay.
The reason why we had this webinar today was to let the participants know that they have a great opportunity of joining us in Mexico City. So
okay, good.
In-person
And
event.
where is it located, the Congress?
The Congress is located at the Hotel Fiesta Americana in Mexico City. It's in Ciudad de Mexico in Colonia Juarez, and it's the Reforma location. So that's all available with the program, the number I shared. I can share the number one more time. If they would like to send us a message, we can share details on the location.
Yeah, everything you say in English is translated to Spanish, so don't worry.
Oh, perfect. Thank you, doctor.
Okay, so let's go further. What is my experience with the use of SOD, superoxide dismutase, to improve oxidative stress? Is it better than other antioxidants? Our body needs several antioxidants, but the superoxide dismutase enzyme is very potent to neutralize the worst free radical, which is the superoxide anion, that's oxygen alone. And that's extremely toxic. So that's important. Now, how do I work? I don't give superoxide dismutase. I give the trace elements that it needs to act well, like manganese and zinc. So I check manganese and zinc levels. And if they are low, I will supply them, and superoxide dismutase improves. But it's certainly important, but not the only enzyme. So I wouldn't work. I work always multiply with the right dosing so that everything is balanced. Okay, good. So let's go a little bit further. And this is in Spanish. I have a patient that has menopause before age 45. And no, it doesn't take, I think, TRH. He consults since age 55. What sort of treatment should you give? If
Yes, what treatment should you give her? Yes, correct.
55 years. Well, basically, first of all, if the patient has early menopause, she needs female hormones. So you absolutely need to give the female hormones. And the TRH is let's say, not the main treatment to give. You need to give the female hormones. And generally, those patients also have thyroid deficiency and some growth hormone deficiency. You need to supply that also. And don't forget that when you give the female hormones, you also need to give testosterone. It's a combination. So you need to give multiple hormone replacement therapy. And I think the question is, for a 55-year-old, you would give the same sort of therapy that for age 45, only the doses are a little bit higher. How to control the, how to check, it's a Spanish, how to check growth hormone in women and in men. Well, basically it's by doing another test. You check insulin-like growth factor 1, IGF-1 in blood, and you check the binding protein of IGF-1, IGF-BP3. And you should have a high IGF-1 and a low IGF-BP3. And that's as well in men and in women. This checks the growth hormone activity. Growth hormone you cannot check in blood during the day. It's undetectable. It's mostly at night that there's a high level. There's a little bit in women and some peaks in men during the day, but it's too irregular or erratic to check, and it doesn't give any good information. So you check the result of growth hormone on the liver, which there it stimulates the production of IGF-1, and that's a very stable growth hormone activity that really reflects how much growth hormone there is in the body. I found this very informative. However, I think it would be more convincing if the study cited when 15 years old. Well, then, Karen, you should absolutely go in the evidence-based hormone therapy. Everything is extremely updated. Or you should swim in my new growth hormone book that has the latest updates on growth hormone. So you're absolutely right. Don't rely on 15 years old, but so you go in the evidence-based hormone therapy. There's enormous information on almost all hormones, on longevity, very, very accurate, and you'll be happy. You go up to 2022 with the formation, and 2023 even with the latest, like the cardiovascular. So you'll be very happy if you like to have the most recent studies, and it's absolutely not 15 years old. My hormone handbook maybe has references, but not the videos. You really, and the videos, I can tell you, I'm fascinated about it, even if I did it, but I think you will be fascinated and you will exactly have what you want, Karen. Buenas tardes, Dr. Hertoghe. Good conference on Quericamento de Inicia. How can you start a treatment with testosterone implants and provide anastrozole and also give finasteride? So that's something that we will discuss actually in Mexico. You generally in most men, you need at least to give anastrozole. And then to give also finasteride if they tend to lose hair. I take finasteride and I take Arousal. If I didn't take finasteride, I would have no hair here. It's in family, we don't have hair. So I have hair, no problem. There's you should with implants do the same, although there's maybe a little bit less conversion of testosterone dehydrogenase with implants. Sorry, somebody's asking me a thing. Yes.
Ouais. Beaucoup de personnes demandent l'indicatif qu'il y a avant le numéro de téléphone que Thomas Brown m'a donné, parce qu'ils savent pas de quel pays le numéro provient.
Okay.
Ils ont besoin d'indicatifs.
Thomas, you need to give us your number with the country indicative of Mexico. People are several asking to get that number. Can you write it maybe in chat box, and I'll try to put it up.
I'm going to say it again in English so everybody can hear my English and Galia can translate it. Okay, so the number is country code 52624-184-8202. That's country code 52624-184-8202.
Good, thank you.
And if you'd like, I can just say in 20 seconds real quick what I said in Spanish to everybody who speaks English online. Galia, feel free to translate. We're going to talk about top 10 hormone treatments, chronic diseases, inflammation, disorders and hormone symptoms for males and females, and also sexual dysfunctions, lupus. We're going to have a great congress with many topics for 2 days on the 17th and 18th with Dr. Hertoghe. The 19th, Dr. Antonio Posada and Carrie Fitzgerald will be joining us to talk about functional medicine and pellet therapy for breast cancer and testosterone. Hopefully that helps to translate in both languages. The Congress will be located in Mexico City at the Fiesta Americana Hotel, the Reforma location. And we look forward to seeing you there. Thank you so much for your time. And Dr. Hertoghe, feel free to continue. I thought English would help.
Okay. Here's why has HRT had such a bad reputation with fears for cancer? Should all women be on HRT after menopause? All women who are after menopause should be on HRT with or without breast cancer. However, there's a fraction of women who should never go on HRT. They're so afraid whatever you say, they have a different destiny. So if they don't want, don't insist. Just present the facts. Also with the studies, there's a lot of studies on cancer now has coming out. So you have also in our evidence-based hormone therapy that is updated from Armando Farmini, from a gynecologist of Austria, who has shown all the studies of cancer protective effect of estrogens and clears that out. So you have that information. But so I would say when the fear is too great, you just inform, you reassure. If it's not sufficient, don't treat, because those patients might, I would say, make their own cancer just by the fear. So you need to try to listen to the patient. What is the patient ready to do? And do your best and not more. So how to initiate hormone therapy? Do you need to have hormone test or just rely on the symptoms? You need to protect your license, so you always need to do lab tests. So I always do lab tests, but I also do take all the physical signs. I do a physical examination, and I have also the complaints of hormone deficiency. And with that, I make a diagnosis, but I always need also lab tests. So the symptoms and the lab test. Listen to your patient, look at your patient, and check his blood or 24-hour urine test. And you have then the information, and you can initiate the hormone treatment. Is there an age limit to use growth hormone? Yes, there is. Once you have reached age 200, then you can stop, because the world will be too populated otherwise. But there's no real, it's a joke, of course, there's no real limit. Even a 100-year-old needs growth hormone. However, the limits are, you need to be careful. If a person has cortisol deficiency and you give growth hormone, you can decrease the cortisol. So try to know enough about the treatment and give each person the right dose in the right balance with other hormones. Melatonin can improve the male fertility too. I don't know. If you sleep better, you probably have more hormones made. It's probably better. It's also antioxidant, but I didn't find a study that improved male fertility. I did find studies where it improved pregnancy. So in pregnancy, you can give it. I thought long that you had to be careful in small doses, but there are studies done with higher amounts and give good results, actually. It doesn't have adverse effect. But for males, I don't know. What about the testosterone treatment in men with prostate inflammation? Men, is it safe to use? Teresa, yes, you're right to worry, but it's exactly the treatment you need to give when there's prostate inflammation. So I have patients who had always prostate infections. Of course, I do a local treatment. I give suppositories of a disinfectant or eventually of progesterone and of good nutrients that decrease prostate cancer. But basically, I ask these patients to stop alcohol, because each time they drink alcohol, the next day they have a prostate infection. But it's the testosterone, when you give testosterone, it will strengthen the prostate, who needs male hormones for its good function. And they will have less prostate inflammation. I have men who never had, again, prostate infection, while they had all the time prostate infection, but they were on testosterone and they stopped drinking the alcohol. If they drink alcohol, the next day they get their infection again, with or without testosterone. Now, here's a question in French. I'll translate it in English. How to take dydrogesterone, that progesterone that is protective against endometriosis and premenopause. With irregular cycles, can you continue Dysfunction continuous? I wouldn't take Dysfunction continuous, and I would restore the cycle. So if a woman with endometriosis has irregular cycles, that means she has estrogen deficiency. They're not stable estrogen. So I would always give a dose from the 5th to 25th day of the menstrual cycle of estrogen, like 2 pumps or 3 pumps of transdermal estrogen preparation. That's about 2 milligrams of estradiol. And I would also give, then if it's severe endometriosis, I would give from the 10th or the 5th day 5 milligrams of dydrogesterone or Dysfunction, and then from the 14th to 25th day, I would get 1.5 tablet of Dysfunction or 2 tablets. So that's about 20 milligrams, 15, 20 milligrams, and that works out well. So you need to have a regular cycle, even with endometriosis. It's more easy to do than you think. Of course, a woman may not eat whole grain bread, because that gives up to 5 times more irregular cycles. So no whole grain bread, that must be finished. So I have a thank you word here. I'm from Brazil. I would like to express my gratitude for the lecture. Okay, my question pertains to subfertility in young premenopausal women. when they have symptoms of deficiency of estrogens like vaginal dryness, droopy or small breast, spasmodic dysmenorrhea, that's already a doctor who knows more about, along with low estradiol levels in luteal phase, etc., as well as signs of progesterone deficiency endometriosis. How frequently have you witnessed an improvement in fertility with estrogen and progesterone treatment in your practice, considering that other hormone deficiencies such as thyroid cortisol are also being evaluated? Additionally, what estradiol dosage do you consider appropriate to initiate in this scenario? So this is a question that women who are young, but they are not making enough female hormones, not enough estrogens, and even less progesterone because they get endometriosis. So I would give, again, a cycle. I would give estradiol, maybe something like 1.5 milligram of, not more. I wouldn't take between 0.75 milligram to 1.5 milligram of estradiol from the 5th day to 25th day of the menstrual cycle. And I would give, like I told, progesterone. But however, if they want to be fertile, you cannot start the progesterone before the 17th or 18th day of the cycle. So you have to be very cautious of starting later, because otherwise the progesterone closes the cervix and there's no sperm being able to come in the vagina. That's one of the reasons you need to start later. And because you start later, you will probably only have to give a small dose of estradiol, 0.75 milligram, to one who has endometriosis, while she has also a lack of female hormones. Of course, you in stimulate, give the thyroid and cortisol, because then they are better. Now, also, I'd like to know if finasteride 5 to 10 milligrams is safe in the long term when added to estrogen, progesterone, and testosterone therapy in women. I've read something about reports increased male breast cancer in men taking finasteride. Yes, it is normal. Finasteride is a blocker of the conversion of testosterone to dihydrotestosterone. So if you block the conversion of testosterone to dihydro, you will make from testosterone more estradiol, because that's the next conversion. So men who take finasteride get higher levels of estradiol, and they have to take anastrozole. Otherwise, they get too high levels of estradiol. They will not get breast cancer, and normally not. I can never promise, but normally not, if you keep the estradiol levels on acceptable level, low normal, like 24 picograms per ml. That's optimal. And so I take finasteride, but also take anastrozole with my testosterone treatment, and I do fairly well with this. And I had a time where I didn't do well with this because I didn't check on time, and I had done an increase of prostate size. So I decreased the prostate size by 3 times, I think, or at least by a PSA of 6 to 2 back by suppositories of progesterone. So no worries, you can really arrange things even after, but you need to try to be on time anyway. How do you supplement with testosterone, and which form do you use, please? I use either a transdermal testosterone, for men liposomal 10%, for women the gel is sufficient 0.5%. They put it on the inner arm, but the men put the testosterone transdermal on these places here, and where there's no body hair growth, okay? And I use also injections. I take myself now, I've converted to testosterone injections. I feel much better with that than with the transdermal, but I had a transdermal that didn't work well. So I'm changing firm who makes it. I found another pharmacy can make better ones. So I'll probably put other patients again on this transdermal, but I feel so good with the injections that I'll stay on the injections. So that's it. So in women, you can also give transdermal injections, but the dose is much lower, and it's with finasteride. At which age normally you should start as a healthy man start with testosterone, DHA, growth hormone, and other hormones before aging? It's not pathological with. So could you give hormone precursors to keep them young and now? Okay, hormone precursors work a little bit, but never much. So it's never a fantastic treatment. Hormones are always a fantastic treatment. You can start at puberty if it's necessary. You can start at young adulthood or later. Most patients around age 30 need to be on multiple hormone replacement therapy, because then you really get sharper declines. And I would say latest between age 35 and 40. Later is quite late. It's better to start earlier. I wouldn't believe too much on the precursors. I have tried everything. I have tried also improved by the food, but nothing is better than also giving the hormone next to doing all this. You can give a precursor, but you still probably need to give the hormone at age 35. What about testosterone pellets? It's a question in Spanish. Yeah, so I'm not an expert in implants of testosterone. I think they work well. I like to do treatments where you monitor better, like transdermal testosterone and other things to give testosterone. But there are many people who don't want to care about their body, but they care, but they don't want to do too much effort. Their implants are probably perfect because regularly they have the right dose, they feel good, and many of those patients still feel dynamic. So I think it's good. However, you need still to check estradiol levels and understand the algluconide levels, the metabolite of dihydrotestosterone, to see they don't get too high, or you have to correct that. So it doesn't change. Now, what is best sexually in general? Well, be there in Mexico. I'll talk about it, and you'll really get the information, because it also depends on what the sexual problem is. But there's a lot we can do, and very powerful. I showed you just the example that when you take, well, I didn't show you the example. Actually, the example of MSH, Emontan-2, that improves sexuality. But there was also another study where the patients had an erection was taking Cialis and Viagra, and then they added the MSH, and it was 10 times longer erection, better. So you see the difference, and that's just one of the hormones. So do you give other hormones than bioidentical hormones? Yes, sometimes I give other hormones. We're going to stop. Well, I'm going to see if there's some. Can you obtain the books in Spanish? I only have one Spanish book that's translated for general public. I'm not sure about the title. It's something like Stay Young for Longer. And okay, I'm going to give last questions. I have some knowledge, but what can do patients like myself? Now, doctors with relative good knowledge of medicine by themselves to keep their hormones at the right levels. And in book for patients, we have the hormone handbook, the patient hormone handbook, that has all the guidelines also for vitamins. So patient hormones, very good book. Any additional resource for patients, any internet links for patients? Well, you can always get the information we have in YouTube videos. So just put my name and you'll find YouTube videos. There's information for patients. There are general public books. I wrote The Hormone Solution, for example, is one of the books. So that's it. I thank you for being there. I thank Thomas for giving the opportunity also to talk. And I hope to do a very good workshop there in Mexico and that everybody will enjoy. I'm sure the topics are extremely interesting and you have a lot of updated information that will be given there. So I hope to see.
Thank you so much, Dr. Hertoghe. That was a great time. And I think all the doctors are just wishing that tomorrow was November 17th, so they can learn more as soon as possible, because I know I sure do. Thanks again for your time. And then, mis estimados médicos, si algún más pregunta o comentario, pues pónganse en contacto con sus representantes de ventas. Nos vemos en noviembre. Muchas gracias. Thank you, Dr. Hertoghe.
Welcome. Bye-bye.